Rob walked in and said, "Oh, hip pain, this is boring. I'm going to leave."
Yeah. Or
something like that. But no, I'm going to more talk a little bit about my history of why I love what I do, why I got into it, and hip pain is just going to be an example of discussing it. My kind of career in medicine started as a 15, 16-year-old when my parents got me, I don't know why they got this for me, but they got me the season 1 of CSI. Did you guys ever watch that? I was like, what is this? So I watched it. I was a little bit terrified of it, but I actually got really interested in it. And I loved the idea of how they solved the crimes. And it was the idea of you could take all of the evidence and it would just show exactly what happened. You could see blood spatter, it would be a certain direction, and you could see how the crime was done. And that really intrigued me. Like, wow, you could use science to help kind of figure things out and kind of like modern day Sherlock Holmes. And I really love Sherlock Holmes, both my favorite actor and then also the newer series of Sherlock Holmes. Really enjoyed that. And that really got me interested in kind of a different aspect of a career in my future. When I grew up, I thought I was just going to take over my dad's business. When people say, well, what does he do? I'd go, I don't know. That just was my thought, is just to do what my dad did, right? But then the idea of what I could solve things on my own would be interesting. And so I really enjoyed kind of crimes, not crime, but just solving puzzles. And Sherlock Holmes has always been a favorite of mine. And the idea of being able to find things. So one of my favorite quotes is, when you have excluded the impossible, whatever remains, however improbable, must be the truth. The ability to find truth through evidence of things around you. Now, obviously in medicine we'll talk about that, but we've all done this, right? Now, the first example for me is when I'm sitting in church and someone walks by like that. And I lean over to my wife and say, she's like, no, don't tell me, I just don't care. I do that all the time. Or someone will walk like this, or with a silly walk, I'll be like, did you know that's a hip abductor weakness? My wife will just be like, I don't care. But just the ability to look and go, okay, I can figure out what's going on based on some evidence. And so when someone comes, and specifically in my clinic, they come in with hip pain. This is what they usually will present with, something like this, one of these three. My hip hurts, right here. Or my hip hurts, right here. Or my hip hurts when they point to the back. And as part of my job that I actually love is being able to take these clues that they give us and really try to figure out what it is. And hopefully today we can talk a little bit more about how we can be a little bit more like Sherlock Holmes and not just saying, oh yeah, that's hip pain. Well, but which one's hip pain? They're all different locations, and patients may have a different perception of what hip pain is, but our ability to truly find out what's going on is kind of the fun part. Before we start to investigate, let us try to realize what we do know so as to make the most of it and separate the essential from the accidental. I think a lot of times in medicine and in our clinics, we get kind of on the doldrum of the typical thing. Oh yeah, hip pain, it's here, yeah, I know what's going on. Rather than stepping back and going, wait, what do we really know about this? Let's take away our bias and let's actually think about what may be happening. So my goal today is to really help us to step back and remember what we do as clinicians is really investigation, and we need to be unbiased, and we need to be a little bit more like Sherlock Holmes. And that's why I love the Sherlock Holmes movies, the books, is because Holmes will walk into a room and everyone will say, oh yeah, this is obviously a suicide. And he'll step back and go, no, it's not. And they're like, well, how do you say that? And he goes out all the different clues that everybody missed because they just looked for one thing, which was a guy had a noose and he had hung himself, and it's suicide, it's cut and dry. Well, no, there's so many more signs to it. So hopefully we can do that. So when we're looking at hip pain, specifically that one picture I showed you, those 3 different types of hip pain, what should we do to find out which is which, right? Because this is hip pain, this is hip pain, this is hip pain. And some patients actually say low back is hip pain for some reason, right? What are some of the ways we can help really delineate what that is? Obviously, for me, it's just like Sherlock Holmes would do, right? He'd walk in and the first thing he would do is he'd look, he'd be observant, but then he'd ask the questions. And then along with the questions, he'd be more observant as how they responded, why they responded in the way they did. I think, again, I love that part of my job is really the patient interview, is really finding out. And so as Sherlock Holmes says, what we need is data, data, data. You can't make bricks without clay. So some of the find out questions we need to ask. Where does it hurt in the hip? What makes it worse? What do you avoid doing now is one of my favorite ones, because that tells us a lot more than just, oh yeah, it hurts in my hip. Well, okay, well, what do you avoid doing? Well, I try not to ride in cars anymore because I can't sit. Okay. Or I don't like to lay on my side. I'm usually a side sleeper. Oh, okay, right? All those little things which may not be the typical questions we ask, which is where does it hurt, but more of a why is it stopping you? So maybe, again, bringing up the Sherlock Holmes is thinking about our questions in a different direction, not just asking your typical ones, but what are some Sherlock Holmes inspired ones that would be a little bit more data driven and not just, hey, these are the questions I ask, right? The OPQRST questions, the onset, provocation, severity, time, radiation. What makes it better? What makes it worse? Stiffness versus pain, active versus passive motion, and then the type of pain. Okay, so you say it hurts, but what does it feel like? And again, even that's difficult because they may say, well, it's sharp. Well, but is it sharp like burning? Is it sharp like stabbing? Oh, well, yeah, I guess it's more like burning. If you don't ask those questions, you may just assume that, oh, it's a burning pain, so it must be, back and nerve related, right? So I've got a couple pictures here that kind of help with this kind of map, or a CSI style, that usually if it hurts here, then this is usually where the issues are. But from the front of the hip pain, these are some general areas of where patients can sometimes describe pain. But remember, I'm sure you guys have had it that a patient will complain of hip pain and it's in the front of their hip, but it's their back, right? We notice it is, we know it's the back, but why is it that it hurts there? And we know that the brain is wired a little bit differently for everybody, right? The big example I give patients, they may say, well, geez, how is this my back if it hurts in my hip in the front? And my favorite example is to talk about how the brain understands a heart attack, right? With a heart attack, where do you grab your arm when someone has a heart attack? What do they always do? Oh, it hurts here. Why does that happen? Anyone know the real answer? What's that? Yeah, so it's a referred pain, but it's not really referred from the heart because the heart doesn't feel pain, despite all the romance novels and Hallmark movies that we watch, right? Right? It's actually just the brain going, there's a problem, and there's got to be somewhere it's happening, and so it pulls the closest nerves. The closest nerves are going to be near that left shoulder region, so this is a heart attack, right? And it's similar with hip pain, right? Or with any other referred pain. It's the brain trying to go, I don't truly understand what's going on, so I'm going to say it hurts in this location, right? And so sometimes we can get fooled. Or in the back of the hip, sometimes you'll see and see is actually, even though that may be considered piriformis syndrome or deep gluteal syndrome, we have patients who complain of hip pain. When I twist on my hip, it hurts like this, and they'll point through and through, and they'll point buttock. And usually the first thing is, oh, it's buttock? Oh, good, I can just send that to John or Brandy, and I don't have to worry about it anymore. No, right? We have to actually sit and be sleuths. Or side of the hip. A lot of times you'll say, oh, if it's the side of the hip, what's the problem, right? IT band, trochanteric bursitis, right? Cut and dry. Well, no. We have patients where if they get an intra-articular injection, their lateral hip pain went away. Why? Well, again, where does their brain understand their pain to be? So even though we may want to just look at these areas and go, yeah, this is definitely where the problem is, we have to remember that everyone understands their pain a little bit differently. So again, going back to Sherlock Holmes, when patients walk in, my favorite thing to do is to sit in kind of our middle core. We have 2 hallways in this middle little core. I sit there and I usually will watch patients walk in. So as they walk in, I'll talk with them, and then they'll go in the room and they'll get all set up, and I'll come in and do more discussion with them. But it's fun because I'll just sit and observe and watch them. Now, some of them think I'm probably a creeper, so I'm watching them walk in. But realistically, I'm trying to look at their non-awareness cues that they're giving out, right? That Sherlock Holmes of, I notice when you're walking that you have a little upstep, which means your shoe wear on your right side is a little bit worse, and so this is your problem, and you were the murderer because you whatever. that idea of just being observant with everything that we're doing, how they're sitting in the chair when you walk in, right? Sometimes we won't even think about that, or where do they position themselves, and if they're sitting up on the exam table with one leg up and the other one down, I mean, that's the affected side. Is it truly as painful as they initially talk about, right? There's things that, some non-verbal cues that you can get from it. But some of the main things I look for is obviously a Trendelenburg gait, a shortened stance. If they're leaning forward, if they're leaning back, which affects their pelvic tilt, right? And then with the hip exam, one of my favorite and most important things that I do with all aspects of the body is really delineating between active and passive motion. I think that's one that we miss a little bit, right? And the example that I love is this: the idea that muscles and versus tendons and bones are very, very different, right? Active motion is specifically a muscle-driven issue. But if you take the muscle out of it, just like the tendon and the joint don't really like the muscle, you can actually you can really determine if it's more muscular or if it's more joint or nerve related. And so a passive motion test is so important. And that's one of the other reasons I got into medicine, is when I did my athletic training in high school. I was an athletic trainer at the school up in Wasatch and Heber, and I diagnosed someone with a rotator cuff tear, an acute rotator cuff tear in a 16-year-old. And the trainer's like, "How did you know that? Like, that was amazing." And I was like, "Well, it's easy. You know, I could passively move it, but he couldn't actively move it." And they're like, "Oh, well, you listened in class." Like, okay, thanks. But some of the other important exams to do, for me, the fader exam, right? Flexing the hip up, adducting it, internally rotating it. But again, that doesn't always just delineate, oh yeah, it's definitely hip arthritis. No, it could also be associated with FAI or labral tear. But the key thing for me is not just doing the fader, but what's the actual passive motion you can get out of it. Because if I do a fader exam and I go all the way to 45 degrees of internal rotation and then it hurts, well, that's going to be very different than just a positive fader. So for me, if I look at a note and see a positive fader, that really doesn't mean a ton, right? Because it hasn't eliminated it. But doing a positive fader with understanding range of motion, like positive fader at 5 degrees, okay, yeah, that's going to be more hip related, right? Versus a positive fader at 60 degrees of internal rotation is going to be more FAI style, right? So again, not just going through the day-to-day observation and hip things, but actually going through as a sleuth, as Sherlock Holmes would do. Or a Faber exam, right? A Faber exam, usually if you have a positive Faber, that relates to what? What's the test? What's that for? Right, SI joint, right? But have you done a Faber exam in someone with hip arthritis? It's positive, every time. Now, does that mean that a Faber means you have arthritis in your hip? No. But I think, again, not just going through our day-to-day hip exams, our day-to-day, again, this applies to shoulder. I just picked hip just to talk about hip, but the same thing applies with all that we're doing, is stepping back and thinking, why is this exam important? What information and evidence does this give us? Or a Thomas test. Thomas test is where you lay them flat on a table, flex up their hip as max flexion as you can get, and watching what the opposite side does. Why is this important? Right, hip flexors, right? If someone's complaining of hip pain and it's right in the front and it's in that groin and I start to salivate because it's time for a hip replacement, some of the issues actually may not even be that it's the actual hip itself, it's really more the muscle, right? And that can obviously be blocked on it. But also very important for me, if I'm going to do a hip replacement anterior, which I do, I need to make sure that they don't have a contracture, because when it's time to bring that hip down during surgery, that can't stop me. Or Stinchfield test. Stinchfield test is just simply active resistance at 45 degrees when you're flat. You can actually do a poor man Stinchfield, which is where they're sitting, and you can have them lift it and do a resistance while they're sitting, but this is the actual way to do a Stinchfield, and you'll get positive pain with resistance. Again, if that's positive, they say that's osteoarthritis, but if someone has a positive Thomas test and a positive Stinchfield test, what could that delineate? Maybe it's the hip flexor, right? So again, I'm kind of beating a dead horse here. The idea that our physical exam can be more than just positive and negative tests. There's more evidence involved with all the different things that we're looking at with our patients when we're observing it. Straight leg raise. Okay, so Brandy, what's a good straight leg raise that you do?
What do you mean by that?
Yeah, tell me about your straight leg raise and what it means to you and how you perform it.
Usually I'll just have them sitting, try straight leg, and then sometimes I'll do it laying as well.
What does it mean if they have it?
Can mean that they have nerve-related pain.
Yeah, so I baited you and you did it right. It can mean that, right? So a positive straight leg raise in general can be also considered a Stinchfield test as well, right? Because sometimes, how often is your patient and you're trying to lift the leg, they help you? All the time. And you always have to tell them, relax, right? Just don't help me, I'll do it, pretend you're a dead fish. And no one knows what a dead fish is, right? They just help you and you're like, no, let me do it. So a positive straight leg raise can be actually incorrect as well if we're not paying attention to if they're helping us or if they're giving us their full weight of their leg, right? So again, straight leg raise in general is going to be looking at nerve-related stretching of the actual nerve, the nerves themselves, and if it's a positive, it usually should be the back of the leg and runs down. But again, if you say, hey, does that hurt? And they go, yes, well, it could actually be that they have no hamstring flexibility. It could be that it's the nerve, or it could be muscle related. So asking, okay, what does that mean? When I do that, what does that feel like? Oh, it's a shooting pain from my butt all the way down to my toes and they're on fire. Okay, that's a straight leg, a true straight leg sign, right? But again, that if it's a negative straight leg, or if you do it a different way, it can still give you lots of information. It's another exam that I love doing if I'm more confirming something. So IT band tightness, right? You lay them on their side, flex up their hip, and then first thing you're actually supposed to do, as Ober described it, was actually releasing all of the capsular tightness. So you're supposed to do some passive motion, and then you bring it into extension and then adduct it. And if it doesn't touch the bed, it's a positive IT band, right, tightness sign. But if they've shown if you actually don't release all the muscles as you're doing a passive motion, that it's a incorrect test, and it actually can be false because it could be piriformis, it could be a lot of different things involved. So making sure you do a passive kind of hip motion and then bringing it into extension and adduction is when you actually truly get a Ober test. But for those who are complaining of pain on the side, confirm it with an Ober test is really the standard of care that we should be doing. Okay, so we've talked about different things. We're going to go through a few patient examples now to help us understand, not understand, but help us to kind of think again like Sherlock Holmes. So you've got a 77-year-old female, comes in with hip pain, right? That's what I see on my EMR as I walk in. And as I walk in, I talk with her. I'd watched her walk in. She had a walker. She was very antalgic, very Trendelenburg style, very hunched over, very stiff gaited posture. She's seeing Alex, and then was sent to see me to rule out hip issues versus back issues. She was diagnosed with Alex as having a degenerative spine, severely degenerative spine, and was sent to say, hey, is this more hip or is it more back? So what do you want to know about this lady? She's a sweetheart. What questions would you ask to help delineate what's going on? I mean, she's got degenerative spine, so we know what's going on, right? Game over. Definitely the back. Well, I don't know why they wasted my time sending her to my clinic.
Does she have any pain going down her leg? Could you describe what the symptoms feel like?
Yeah, starts in the low back and runs down her leg.
Movements that trigger the pain?
Walking, sitting, constant standing. She used to ride her bike for miles and miles and hours, but just over the past month, just something changed. Just can't do any of that anymore. Can barely walk.
How long has it been going on, and then is it constant or
Yeah, it just started, like I said, about a month ago, and it's constant. Nothing makes it better. It's just all the time. Rob?
Are there any aggravating
Oh.
factors?
Standing, walking, sitting, laying.
Anything that makes it worse more than others?
Worst probably is in a sitting position and riding in a car. That's the worst.
Any relief when she gets an inflection?
Yeah, she usually likes to lay down with a pillow underneath her legs. That kind of helps a little bit, but really she can't find any comfortable position.
Can you point to where the pain seems to originate from?
It's hard because sometimes it's here, but sometimes it's kind of here as well.
What does she avoid doing now?
Very good. She doesn't like to bike ride anymore, and she just tries not to move her legs. She tries to just be real stiff, just kind of two pirate legs walking, right? Two peg legs.
So, and you might have covered this, is this one leg or both legs?
It's both legs.
Okay.
And how far down the leg does it go?
It runs down to about mid-thigh on both sides. The left side is a little bit worse than the right side.
What's her hip internal rotation like?
Great. So now we're getting into actual test exam. She can internally rotate to maybe 5 degrees.
Is there any sort of inciting event? Or just
Not that she thought of. She couldn't really think about anything that caused it, which is the weird part, and which is why everyone told her it was her back is the main issue and she should go get seen, because she already knew it was her back, right? So it probably just got worse.
So no history of falls.
No falls.
Any surgical history?
Hysterectomy. What else? Nothing back or orthopedic wise.
What's she done for this?
This is it. Seeing Alex was, I mean, that's what all of us do, right? When you're looking for answers, you just go to Alex. That's what she did.
You said she came in on a walker. How long did she use the walker?
Yeah, just a couple weeks. Her family finally made her. She has medical professionals in her history.
How long ago did she have the hysterectomy?
30 years ago. Just a while ago. Yeah, a while ago.
On that hip internal rotation at 5 degrees, what's the end feel like? Is it painful before it hits the end?
It's painful the whole way, and it is hard as a rock. Good luck if you try to push it, she'll smack you. Luckily, I was like, whew.
Is that the same on both sides?
Same on both sides. Yeah.
Hip flexion?
Hip flexion to maybe 50, 60 degrees, and then it's painful after that. Passive and active.
What's your energy look like?
Great. Let's look. There we go. Right there. What do you see? What's that?
I said she's the murderer.
She's the murderer. That's exactly right.
Yeah.
So what do you see though, Morgan? You say she's the murderer.
Severe osteoarthritis.
Where?
laterally.
Bilateral hip arthritis.
There's the head's deteriorating under the cap.
Yeah, some AVN kind of picture, complete deterioration of her hips. A month ago, that's when this all started, right? Isn't that interesting that this lady has severe hip arthritis, and I covered up the back because this is the only picture that I could get as I was making this. But she had severe arthritis in the back as well, and so when she came to see us, it was what's going on, and so it was a very simple answer, both. Degenerative hip arthritis and severe hip arthritis. Which one was the culprit? Both. They both were. And so then the fun question that I get from Alex is, all right, well, which do we do first? So which do we do first? Is it which one's the main cause of her problems? Something you could do to help figure that out.
Diagnostic injection. Clarify.
Yeah, so diagnostic hip injection. We injected both hips. The left side got about 80% better for 2 weeks, and then the right side was not very much, not much better, but definitely the left side was significantly better. But during that process, even after the injection, she still had pain running down her leg. So, after talking with brilliant Alex, we recommended that she actually get her back fused first, and she did, and then we did her hip. After she got her back done, she had 30% relief of her pain, which I thought that was interesting. But she no longer had pain in the back. But when I asked more about that, I asked, okay, 30% of pain relief, but I mean, how much is in your back versus your hip? She said, no, it's all here now. So realistically, she got complete back resolution from her surgery, but just now the hip was more upset and irritated.
So help me understand your reasoning here. I would have gone the other direction because the recovery from hips is easier than back.
No, and that was exactly it. So we talked about the two issues here, which was, is it better just to get the hip, and that was a majority of her pain on the left side versus the right side. But given that she still had pain on the right side, it affected both legs. And so because it affected both legs, her back pain, our thought process, hey, let's get her back set and then we'll deal with her hip. Because she never had complained of any hip issues at all. So my biggest fear as an orthopedic surgeon, I know you've dealt with this, is what if I do a replacement and they come back and go, great, I don't feel any different. That's the worst thing I want to think about.
Since that in a set of x-rays like that, that's very rare.
Yeah, I completely agree, but I don't want it to be that one time, right? And that was my biggest concern, is she got some relief on that left side, but if you remember, look how bad her other hip is, and there no relief with an injection into that hip.
But that makes me wonder, did you really get in the joint space?
Great point, and this was a fluoroscopic injection, and it was confirmed in the joint. So same thing, I bring those questions and I go, God, I just wonder if they missed it. But going back and looking, you can see it was in the joint, right? And so that's the hard part is, again, as Sherlock Holmes is, what's the right answer in this lady, right? And so for her, it was nice for her to, because the family was nervous about doing a hip replacement, let alone the fact that they need both. This was a shock to them when they got that hip x-ray. They're like, but it's really been all back, and we know that for a while, and how did no one let us know this was going on? And after a month, she had degeneration after a month.
I know that the outcome of hip replacement pain relief is more reliable than spine surgery.
Yeah, I don't disagree with that. But after talking with the family and the concerns that they had, specifically with the right side not improving, that was the plan. And she had the surgery, and then she was cleared after 2 months, and we did her left side.
Did you do any injections for the back before the fusion?
Yes, she had them, and they helped quite a bit. And that was the other thing that was odd. It was, okay, well, those helped, so is it the hip or is it the back? And so the answer is both. Obviously, in this lady, we did her left side, and then we've actually recently just done her right side as well, and she has no pain, zero pain. Hips, back, all of it, right? And so happy with the outcome. Again, we could go back and forth on front, is it back versus hip, which one should you do first? But in this one, this turned out well. And for me, it was, again, a great example of sometimes you can look at hip and go, well, geez, it's the hips. But she got significant relief from the back as well. So again, Sherlock Holmes, not just looking at what's in front of us. Here's another one, a 45-year-old male, history of right hip pain. Worse with sitting and activity, better with rest, unless they're laying on their side, and then significant amount of hip pain. What do you want to know based off this x-ray and based off those initial complaints?
You said no trauma?
No trauma, just general.
What does he do for work?
He is an accountant.
Where exactly is the pain?
All right, pain's on the side. Right, so this x-ray is not super alarming, right? Dr. Jackson, what do you see?
Femoral head and neck junction's a little.
Ah, bingo, right?
FAI.
That's exactly right. So you definitely have some FAI going on with this x-ray. On the exam, negative Faber, point tender over the lateral trochanter along the side of the leg, right? So the x-ray, which as an orthopedic surgeon is my bread and butter, that x-ray and the read that I got was FAI, and I can see that. Go, this is FAI all day long, right? But with a negative Fader and a negative Faber, positive Ober test. Doesn't hurt with any type of flexion, adduction, internal rotation. So x-ray results tell us it's FAI, but his exam tells us it's what? IT band, trochanteric bursitis, right? So this guy got physical therapy, IT band stretching, injected his trochanteric bursa, all better, no issues. But he's also been counseled that he has FAI, whether he's symptomatic or not, and to be aware of it, right? So again, x-rays can be misleading. Evidence can be misleading if you're just looking for evidence and not putting the story together.
What's FAI?
Femoral acetabular impingement. So where you have a little bit of bone growth up on the junction of the femoral and the head and neck, where you get impingement across the acetabulum. So to summarize, it's a capital mistake to theorize before one has data. Insensibly, one begins to twist facts to suit theories instead of theories to suit facts. I love that we have the ability to talk to patients, but then also ignore what they say and look at the evidence, and then put all the data together. And that's the fun part, I think. I love being able to investigate, like Sherlock Holmes, what patients deal with and go through, and be able to determine what they have. So don't let bias cloud your investigation. Great, thanks.